right now is there are two ways that we can administer IVs as far as measurements. Okay? You can do drops per minute, or you can do milliliters per hour. Now, when I say milliliters per hour, sometimes I say cc per hour. Cc per hour and milliliters per hour is the same thing. Okay? I was taught cc per hour, so that's why it's very difficult sometimes for me to say ml or milliliter per hour. Okay? Physicians, when they write the order, because they're all old like me, generally say cc's per hour. The new doctors, the young ones, say mLs per hour. It's the same thing. So get in your mind that you know when you see that measurement, it's the same thing. cc's per hour, milliliters per hour. You can only, this is what I want you to know, you can only give cc's per hour / milliliters per hour via a pump. You've got to have a pump to run it. The good thing now is that the majority of our patients have pumps. Do you know why? Now, when I started over on the Mayflower, we never had a pump. We had to run everything by gravity. So how do you think I'm going to measure gravity? Drops per minute. Why do you think we trying to get away from that drops per minute?
Because it's not accurate.
It's very difficult to get it accurate. I will tell you one story before we start. Is I had a patient, 80-some-year-old lady, weighed probably about 90 pounds, and my order was to run it at KVO. And I'll tell you what KVO means, just to keep the vein open. So she really wasn't getting a amount of volume to help with her status. It was just that we wanted to make sure that the vein was open in case she did get into some trouble. I went in by gravity, started counting my drops, went in 15 minutes later just to see if it was doing okay. The 1,000 cc bag had infused. Wow. The entire bag. When she was only supposed to be getting about 20 cc's, 20 to 30 cc's an hour, I had given her 1,000 cc's of fluid. What do you think happened to that lady? You just went over fluid and electrolytes. I overloaded her, didn't I? And what did she go into? Increased volume on an elderly patient. We give them a lot of fluid. They're going to go into type of heart failure. Did you say that? Yeah. Congestive heart failure. I did that to my patient. It was my fault. You think a lot of other nurses had done that as well? So now do you know why we have pumps? Because it's more regulated. I have control of what's going on in there. And now I want to see a pump. I want to do that because I know without a shadow of a doubt that that patient, via my machine, now machines mess up too, via my machine, I know that my patient's supposed to get 125 cc's an hour. All I have to do to that machine is do what? 125 cc's per hour. And that is how much fluid my patient is getting. So that's what I want to see. There are times that we have to run things not like that, but I'll get there in just a minute. But let you know, you've got to understand when you see an order for cc's per hour, milliliters per hour, you want a pump. Can I teach you how to use a pump right now? No, because everywhere you go, they're different. That's why I put 2 different macros here. Because when you go to Northeast, they use Baxter. And with their primary tubing, Baxter is 10 drops per minute. When you go to Rowan, they use Abbott. They use 15 drops per minute. So when you're getting ready to do your calculations, what is going to be the first thing that you need to do when you look at that tubing, your secondary tubing, you look here, on here, in the upper left-hand corner, there is a number there. And what does it say? 10 drops per milliliter. Per milliliter. So before you can do any calculations, you're going to have to go to the hospital that you're at and look at there. Now this is a secondary tubing, okay? But you're going to have to look at primary tubing if you're going to be hanging a big maintenance fluid. Because that's going to be our primary line. Primary means that's the one that's running all the time. Okay? So you're going to have to do, before we do any calculations, you're going to have to go and look at that tubing and say, how is this running? Now, that being said, if you have a pump, should you worry about the tubing?
Of course. Not the drops.
Say it loud.
Not the drops per minute.
Not the drops per minute, because if we have a pump, what are we running it at? Milliliters per hour. Okay, so I'm not going to be doing a I'm not going to be running a calculation for a pump. For drops per minute. Okay, and that'll make a little bit more sense in just a little bit. Okay, but what I want to do now is I need you to get into your minds this when you do the calculations. Keep that fresh in your brain. All right, I want to go through now as I get a this for Terramine tears my mouth up. But I have lost 6 inches and 5.6 pounds.
All right, congratulations.
Since January the 3rd.
What are you thinking?
Phentermine. Not real healthy. But it'll do the job for April the 5th. It'll do that job. And I've been doing yoga. Doing my little go. All right. When you have a bag of fluid, the physician's going to order how many cc's per hour do we want to run this. If you have a patient that you are getting ready, you know that they're going to run 125 cc's an hour. You've got to make the decision on what type of bag do I get, because IV fluid bags come in 1,000 and they come in 500. Now remember, we have to look at the whole patient. Finance is a big thing too, right? Cost effectiveness. So if I have a patient who has IV fluids of 125 cc's an hour, that's a lot, right? Because there's 1,000 in this. Would it not be more cost effective to use a 1,000 cc bag as opposed to a 500 cc bag? Because we're going to, first of all, it's going to be better for us, because if we hang a 500, how many times we going to have to keep going in there and changing it? Yeah, time management? I can't go in there every 4 hours and change bags. I need to get the biggest amount of fluid that I can hang on that, so I'll know which bag to pick. I always pick a patient with a large amount of volume to be infused over an hour, the big bag. if I have a patient who's getting, let's say, 20 cc's an hour, 20 cc's, is that very much? Could I use a 500? Because I don't want that fluid hanging. Because how long is it going to take me to run 500 cc bag going at 20 cc's an hour? It's going to take about 20 hours to run that in it. Is it good for a bag to hang for a long period of time? No. So why would I charge them for a 1,000 cc bag that I know that in 24 hours I really need to pull this thing down, because the longer I leave it up there, it increases my risk of infection for my patient. So I need to look at cost effectiveness as well for these clients, because I don't know if you guys have been in the hospital lately, but I'm telling you right now, it's costing patients a fortune. So we have to look at ways that we can do things like this. This is just a little thing that's going to help with their bill. So we're looking at holistically. So that's my preaching on finances. All right, so I've got a patient who's going to get 125 cc's. That is basically the most common one you're going to see. You're going to see like 125 cc's or 100 cc's an hour. That is most common. And I'm going to go and I'm going to choose my 1,000 cc bag. One of the hardest things for y'all to do is learn how to open these things. Right, Liz? Did we do that in clinical? Was it me and you or somebody was opening a bag and they were sitting there going, guys.
Lotion on right before you get there.
Huh?
Don't put lotion on.
Right, because it's very difficult if you put lotion. Guys, there's a little tiny tear right there. A little tiny tear, and all you got to do is take it. Pull. Okay. And you spend 20 minutes trying to figure out how to get this IV bag out, and it's, very simple, but, you haven't seen that before, so I wanted to make sure that y'all knew how to open these little bags, because you're going to be doing this number right here when you're doing it. All right, so we've got our bag. Now, with a big bag like this, we're going to have a primary bag, or primary tubing. You don't have primary tubing, but it's the same principle. So I want you to go ahead and open up. If you look at your little secondary tubing, it also has, not tubing, I'm sorry, the bag. It also has a little tear on it. Not as pronounced as the big one, but take it and just pull. Same thing with tubing, guys. There's a little tear in there. You just got to find a little tear and opened it. It's on the side where the tin, on the left-hand side, there's a little notch, and just pull this. See while we're practicing? See while we're practicing? It may feel a little bit wet in there because of the condensation and stuff, but it's not leaking. You want to check your bag to make sure that it's not leaking by squeezing it and making sure it's okay. All right, tubing. You got a little thing that you can pull on the side to open it as well. I opened secondary myself. Dang it. It's my primary. Here it is. I meant to do. And look, the ones with some of these tubing, this is the one from Abbott that it has 15. It has a little thing here that you can, and it says tear to open. So isn't it nice to have instructions like that? All right, when you pull the tubing out, and yours is not as long as mine, but that's okay, and you never let it on the ground like I just did, but I'm trying to prove a point. All right, there are things that you have to keep sterile. the top of the cap. Okay, right up here, the top of this plunger thing, or spike, is what it's called. And when someone says, I need to spike a bag, this is what we're doing. We're getting ready to spike a bag. When you pull that cap off, you'll see that it's a little jabby thing. Right? See the jabby? All right, we've got to keep that sterile. So I keep that on until I get ready to spike, because I'm bad to contaminate things and I don't want to contaminate them. Okay? You pull your bag, you have 2 different ports on that bag, correct? Yes. You have one that has a blue little cap thing on it. That is the one that you pull off to spike your bag. Now these just have 1 port. Our big bags just have 1. And all you do is take this little white thing and pull. You want to keep the bag up right, because I've got to keep that. Now see, I can turn it upside down and it not come open because I haven't done what? Kind of spiked it yet. So it's okay. And you'll see nurses put it on the thing and spike it that way. That's okay. It's not a big deal. Because as long as I can keep it sterile, I don't care how you do it. Okay? So when you pull that little blue thingamajigger off, that is where you're going to spike. The other port is for where you're going to add your medication. Now when we start doing this in the real setting, we will add the medication prior to opening up everything. And talking about what we were talking about a while ago, mistakes made when we didn't have pumps. Mistakes were also made when medication was added to piggybacks. Us making mistakes on our calculation on how much drug needed to be added to the medication. So we were not giving our patients the correct dosage. So pharmacy realized that. And so they are now making our antibiotics with the medication either attached to it or already added and labeled for us. So we won't make a mistake on adding all the medication. Now I'm going to teach you how to add the medication to it like we would do it if we were on the Mayflower. But the pharmacy realizes that it's just too much responsibility on the nurse to be doing this. Also, they have hoods that they can prepare everything under that maintains good sterility and make sure that this is clean and sterile so there's no bacteria getting in here. What if the nurse didn't wash her hands prior to? Or she did wash her hands and then she coughed in her hands and then she didn't wash her hands again and started mixing medication and got the bacteria and put it in this bag. So it really has helped us out a lot. Depending on where you are, of course, both of them do it a little bit, or it comes a little bit different. But when we get to the hospital setting, the procedure is still the same. It's just how it comes. Your instructor will help you figure out what you're supposed to do. But the calculations are not going to change. It's how it's prepped. Okay? And we'll add something in just a little bit. All right. So when you take your spike, and I have already pulled my top, so you should have pulled your blue and get a little behind you because you really got to pull it sometimes.
Make sure your roller clean. I just spilled mine.
Okay.
That's my next one.
Close the tubing on.
Getting ready to.
I'm afraid they're gonna lose.
Yeah. Actually, what I usually try to do if we had something like a cup or something is I want you to run it out one time. Because I'll let you squirt it out one time and then you have to go through the whole procedure again. Because if you had a medication, let me back up to explain what I'm talking about first. If you look on your tubing, there is a rollie, a little roller. This is what controls the rate that this fluid comes through the tubing. If I don't close this right off the bat, when I connect this tubing to this bag, what's going to happen? My medication is going to run all the way out, and then what's going to happen? I don't have the right dose because it's on the floor, and I would prefer you not to sap it up and put it back in there and give it to your patient after it's been on the floor. Okay, that probably is not a good thing to do.
I've done it not so many times, but I have done it before, and it just terrifies me to not do it now. It's like
Exactly.
I have to make myself do that every time as a habit, just automatic pilot, just do it because you're going to
First thing, because you're going to do it. Okay, so automatically, once you pull this thing out, go. Now the little rolly is at the top now, isn't it? That means it's open.
Okay, so
When you roll it down, you have now closed it. Another thing that I do, because I'm very anal about things to make sure, is with your primary tubing, there's another little lock. I don't think it is on your secondary tubing. But for double checking Miss Walker, because she's crazy sometimes, I just go ahead and push this to the side. So now I have a double lock. So I'm not going to waste any medicine. I'm not going to waste any fluid on the floor because I've got it here and here. Alrighty? Okay, so now because we've got our clamp locked, I'm going to spike my tubing. Hold it upright. Pull your top off of and throw it. And all you need to do is take this and push it in and slide and twist. If you twist a lot, your tubing is going to twist with it, and it's going to make it not good and patent. So try not to tick. Just put it in and turn it a little bit.
okay.
Hold it upright. And you want to squeeze the chamber. Is this little thing right here. When you squeeze it, you're going to see that fluid fills it up, and there's a little tiny line on the chamber. You want to fill the fluid to that. Can you see the little tiny line? That's where you want to make sure that you fill the chamber full to that little line. If you fill it all the way up, you will not be able to count your drops. Now, when I said drops per minute, it literally drops out. There is a drop, and we have to count it. And we're going to count it in just a little bit, or when we practice. Okay, I'm not going to go to that right now. All right, so now I'm getting ready to connect this tubing to my patient. Right? Because it's an IV. I'm just going to connect this right here.
Right there.
I'm not. I don't want to give my patient all this air.
No.
Well, that's a good thing. I was getting a little worried that I was going to have to sit here and put this air in this patient because air is not good in the vessels, is it?
No.
So it is vital that you know that you have to, what's that called? Prime the tubing. So in order to prime the tubing, and y'all need to be real careful right now, because you're gonna try to get it to the very, very end. Okay? It takes a little bit of time to learn how to maneuver this rolling, because that's how you're going to adjust how the fluid comes down. If I open it wide open, it's going to fly. Okay? It's going to fly. So you want to watch it as it goes down to make sure that you don't spill any of the fluid. And mine's right here. And I'm all the way to the end. All the way to the end. So what is this bag called right here?
What bag?
The bag you have in your hand.
Piggyback.
IV piggyback. It's called an IV piggyback. And we'll do calculations in just a minute, or in the next hour. But I'm going through all this first. Let me show you, because I get really, really a little bit nervous about wasting medications. So I'm going to show you how you can, if you have a primary line, and how you can back prime this IV piggyback when you know how we're going to attach it just like we did. If I can find my secondary tubing. I'm going to attach it just like we did. What didn't I do? Didn't close my thing, did I? All right, so I'm going to, and all of you may want to come up this way because I want y'all to see this. It's amazing. It's amazing what happens. Because I'm afraid that if I have to prime it like we did, and I don't have good control of this little rolly thing, then my medicine's going to go out, right? And that means my patient's not going to get the correct dosage, right? So a way that we can prevent that from happening is called back priming with the primary line. When you have any medication that's added to a primary line, you have to make sure that this medication is compatible with this primary line. I will ask you that. Be prepared. Every instructor is going to say, if you have a piggyback that you're adding to another fluid, you have to make sure that you can run these two together, because if they're not compatible, once you connect this, the medication is going to crystallize in this tubing. And so then we have wasted a medication, and we're going to have to start all over again with another bag, with another tubing, with another medicine. And what are we adding to our patient?
Money. Price.
Money. So that is valuable information. Anytime you add, when it's IV push, IV piggyback, anything that you're going to put together, IV fluids, you have got to make sure they're compatible.
How do you know if they're compatible?
Your drug book tells you. When you look up, so you'll look up your primary line or fluid that your patient has. Then you will look up the medication. You will look, under there it says IV compatibility. It will tell you what is not compatible with. Majority of everything's compatible with normal saline. Okay, so, but I still want you to look it up. You have a patient who has TPN, lipids. You never, I mean ever, run anything with it. Okay? Now, there are some research coming out with a different kind of filter, but every facility does not have that special filter that you can run it in there. So now, and forever hold your peace, never run anything with TPN and lipids. If a patient has a TPN line or a TPN, they're generally going to have a central line, and you're going to have multiple ports that you can give it in. You'll have probably 3 ports. So I would have my primary tubing here, my TPN here, and I would run my antibiotics here. doesn't mean that they're not compatible in the system, inside the person. It means it's not compatible within the tubing and the two medicines. So it's okay once I get it into the patient, it's okay. But when I put it together, it's not going to work. So we never, ever, ever, ever run anything with TPN and lipids. All right? So, let's swallow. So, I want to make sure that I don't waste any of my medicine. So what I'm going to do is I'm going to back prime. What am I going to do here?
Alcohol.
Now, you know that when you clean a port like this, it is not a little,
Scrub it.
it is a scrub. Because where is this tubing been?
Everywhere.
Everybody touching it, everybody gets in the patient pan. Clean it. Clean, 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 clean. Then I'm going to attach this. And this fluid is going to go in here. If this is lower than this, okay, I have to have this one off, and I turn this one on, and look what happens.
Cool.
Fill in
So
the bag.
now, what,
Just fill in the bag.
It's filling the bag, looky there, and it's getting all the little bubbles out. And that tubing is primed, and I did not waste a bit of medicine, did I? So when you do this, you've got your primary tubing here. This needs to be off, because if this is on, where's it going to go? It's going to go straight down, isn't it? It's not going to go in here. So this one's off. Connect here. Now I connect it with it off. Okay? So when I know I've got a good connection and I know it's lower, then I'm going to turn it on, because I don't want to fill this, because it's already been diluted. I don't want to fill it with another 100 cc's. Because if I fill it with another 100 cc's and it says I'm supposed to run it in 30 minutes and I've added a bunch of fluid to it, the patient's not going to get all the medicine. So it's not there to do this. Well, let's just see how much we can add to it. It's there. The purpose is to prime it. Okay? And you can also see how it has a lot that I filled up here. All you have to do is turn it upside down and squeeze it and put that fluid back in, put it back over, and now it's at the line. Now, if you have a gravity, running a gravity, so that's how many, how do you measure that? Drops per minute. I'm going to run this drops per minute, so you can actually see the actual drops running. But let's look here. This tubing is pretty intelligent, and it knows that with the higher something is, the better, the more it's going to run. So my primary line will be calculated. It will be going into my patient. But when I add this, this is going to be on a timed schedule of my drops, i.e. 50 cc bags generally run in 30 minutes. 100 cc bags generally run in 1 hour. Okay? So I've got to make this my primary line. So in order to make this my primary line, I've got to drop this to make this higher than this one, so this is the one that's running. So in order to make this all work, I'll make me a little bag here, because I'm going to probably overflow into my bag. I still want to turn this one on. Actually, I'm going to have to pull it up here so I can. Yeah, will you watch that?
Yeah.
I'm gonna regulate it myself, because I don't want to overflow that thing. In order to make this one run, I have to turn this one on. And I regulate with the primary tubing, not this tubing. So I'm regulating here. So if I have to count a drop, because that's how it's going to, I'm going to count it. And we'll do calculations in a little bit. Our goal is to see how many drops is going to drop within 15 seconds. Okay, and when we do the calculations, you'll understand. So if I had this to drop, let's say I had 20 drops in 1 minute, was my calculation. I would divide that by 4. So I would be doing 5 drops in 15 seconds. So I actually take my watch off and I hold it here, and you see that drop. So there's 1, 2, and I actually count those drops to make sure that I have 5 drops in 15 seconds. That's what you're required, that is one of your checkoffs. You're going to have to count this after you've done your calculations. You're going to have to make this run at the appropriate time. See how it's sort of scary? To make sure that it's running at the appropriate time. So see why we want pumps? We want pumps, don't we? Everything
Pumps
on
reason.
pumps. Every pump. And see, I can make it go fast. One of the hardest things that you're going to learn how to do is control this little thing right here. Because you think you got it going, and then it's going too fast, and it's going too right here. The other thing that happens is sometimes when patients move, they move where the angiocath, and it may go a little bit faster. So if you've got something that's running by gravity, which is measured
Drops
per minute, is you know you're going to run it in 30 minutes. Don't you wait that 30 minutes to go back in there and you got a whole bag because the patient moved and the drops are not going like they should. You need to go in there and make sure every 10 to 15 minutes, go in there and make sure that it's running appropriately. Okay, so you want me to show you that again? Or you got it?
Will piggyback always run gravity, or will you run them?
No, you can piggyback it onto a pump. And the good thing about the pump is when I connect it, this primary bag here will be up and the tubing will go down into the pump. I can connect this tubing to the top of the tubing on the pump and program the pump to tell me that this will, and it actually, once you program it in, it comes back and says, you've got 50 cc's and it's going to run in 30 minutes, and it's going to start clicking the time away, and it's going to see pulling it. So it's not really necessary, although some nurses still do it. If you run a piggyback with a pump, you don't have to lower it. You only have to lower it when it's running gravity, because the pump's going to pull the medicine it needs to pull out of it, because I have programmed it to do the, so what's that called? Secondary? It gives me the option to say, is this the secondary tubing that's running, or is it the primary tube that's running? Another thing that's wonderful about these wonderful pumps is if it takes me 30 minutes to run this, I've programmed it in there, right? So the pump knows that in 30 minutes, this medication should have been administered. So after that 30 minutes, you know what it does? It automatically reverts back to this primary line. So I can't let, because if it didn't do that, it would suck this tubing and this fluid completely dry. I would have air all in this line, and I would have to restart and reprime everything else. Now gravity, it ain't gonna do it for you. You gotta do it by yourself. So you gotta know when you hang that bag at 11 o'clock, you gotta go back in there and make sure that it's going, that it's at 10 after, you gotta make sure it's still going good, it hasn't already flowed in there. You gotta keep an eye on it. Think about if you have 5 patients that are all getting medications at 9 o'clock. Aren't we thanking Jesus for, Yes, because this is taking out so much more, plus it's more accurate. It's telling me, hey, I know this is going in exactly 30 minutes. Whereas with us counting the drops, and I can tell you, when you start counting the drops, before you get it to the rate that you need it when you're practicing, you're going to run the whole bag out. Because it takes a time and you got to practice to know how to regulate it to get the appropriate drops. I can come straight in here. If I know it's 20 drops per minute, I could probably set it on 5 drops time-wise because I've done it so much. You? No, you're not. You're going to run the whole thing out. And that's okay when you're practicing. Get the practicing bugs out here before we get to the patient's room. If you run all your bag out, just go to the sink and fill it back up. In practice, not in the patient's room. But just fill it up so you can, because I really want you to time those. Okay? So just timing it. Do I need to go through this again? Okay, it's been 30 minutes. My infusion is complete. What do I need to do now?
Gotta unhook it.
So I've got to, because I don't have a pump. I don't have a pump. I got to do my drops again, right? So if this is done, this is no longer the what? Primary line. So I gotta put this back up. I gotta
Disconnect.
cut that off, right? And I now have to do what?
Calculate
I'm
the
going to have
drops.
to calculate the drops here because this is my primary tubing and this is what my patient's supposed to be getting every hour. So I have to recalculate.
Should you go ahead and remove the secondary line from it?
Tubing
Or does it matter?
lasts, and you have to go to whichever policy at the hospital, but tubing, the last time I checked, they're making a change, but 72 hours. Miss Beaver, do you know how long tubing's last in secondary tubing at?
If they are connected continuously, they can be for 3 days, but if it's intermittent and you've got several bags hanging and you're taking loose and hook it up, it's 24, is the last time I heard. 72 that stays together.
Right.
Unless you get a legal hit on it.
So this primary tubing can last 72 hours. I know what they're trying to do at Northeast. It's very, very costly to the patient, but you also have to look at it like this. Costly to the patient, but it decreases their risk of getting infection. So I'm okay when I have to charge a little bit if I know that it's not going to put them at risk for infection. Does that make it? It's more, if they get an infection because I didn't clean this port, that cost is on me because I didn't do, so I have no problem. If I've got something hanging, let's say I had this antibiotic to be given 2 times a day, I would use this tubing those 2 times, and after that, I would trash it.
You're gonna leave that hanging until you come in 5 hours later, and you're gonna disconnect it and reconnect it.
Right, and connect it here. Exactly.
And you clean the port and everything, right?
Right. Clean every time you go in and out, in and out, in and out.
So you just go spike to the little bag with
Just
You
Right,
wouldn't
the
even
new little bag.
unhook it from there.
Yeah, I wouldn't. Well, you're right. I wouldn't even have to unhook it here.
You have to clean it and just like
No, you don't clean your spike because it's sterile. Yeah, you can just, because it'll be a brand new bag, and you can spike it immediately. Yes. I'm sorry, I can hear you. Did y'all hear her question?
No.
If you have a pump and the patient moves or they lay on the tubing and there's an occlusion in this tubing, so it's not able to pump, our pump's gonna go, "Rah, rah, rah," and you know what your patient's gonna do? My IV pump's coming, is beeping, you know, and the biggest thing that people do, and it is, I do not want you to do this, is they go straight over to that pump and they either hit silent or they reprogram it. They don't look and see what it says because it tells you, is there a distal occlusion? Where is the occlusion at? What I'm telling you, you can hit silence because it's very annoying. So you can hit silence, but what you need to do is you need to go to that site and you assess that site. Because if it's infiltrated, do you know what it means to be infiltrated? It's out of the vessel. The fluid is not going in the vein. It's going in the tissue. Is the patient benefiting? No. Did you see the pictures that I put up of that IV beginner thing that showed you signs and symptoms of what can happen to a patient if their IV is infiltrated and you don't look at it? Patients can get phlebitis. Their tissue can die because I didn't go in there and assess that IV site before I hit that button and reset it. So I'm telling you now, when you have a pump that goes off, you need to look at that site. You need to look to make sure that there's no redness, no edema, and the biggest thing, you need to listen to your patient because he's going to tell you it hurts. And when you touch it, you say to them, does this hurt when I touch? And if they say, yeah, then you better go and make sure that that site is within, that is not infiltrated and it is looking good. And the way you can do that, to make sure that it's patent, you get a syringe and you put it at the nearest port, like this would be going into my patient, and you put a syringe in here, clean, put a syringe, and you aspirate back, you should get what? Blood. You should get a good blood return. Then you can push the blood back in. It's okay, it's their blood. You can push it back in, you know, not like, but very slowly push it back in, and when you're pushing it back in, you are assessing that patient to see if it hurts. If you get a good blood return, you should be fine, and it's not red, and it's not got any swelling there, it should be fine. But I have to make sure, you should do that every time you get a beep on that machine. You're not going to see that. Nurses do that. But you know what? You as a nurse are going to do that. Me as a nurse, I do that. I can also tell you that if I have a patient who has an IV access with fluid hanging, I assess that site every hour. Every hour I go in and I look and see, and I try to keep it on the top of the hour. Because I know I can say, okay, 9 o'clock, I got this patient and this patient's got an IV, I gotta go check their site. And that's something I put on my plan of care when I'm taking care of somebody, because you don't know how quickly these things can infiltrate. And nurses are not doing that, and patients are getting phlebitis, and our students ain't going to be nurses, are not going to do that to our patients. Okay, we are going to make sure that that IV site is good and patent, and it's not hurting my patient. Okay? All right. Then I will be back.
So on the gravity thing, the lock, is that all you have, like you just walk off and leave it locked and assume that no visitor or anything's gonna mess with it?
Yeah, that's scary. Yeah. That's why we like pumps. Yes. And I can tell you right now, just from experience, the majority of the time that you're going to see gravity IV piggybacks is going to be in emergency situations, and it's going to be in the OR. So you're going to see that in the OR. Are we going to see them counting the drops? No. No. what you're gonna see is, and sometimes I'm okay with that because in the OR, it has to be administered within X amount of time of the incision. So if and they are very, very adamant about that because there is so much research that says if you give them a prophylactic antibiotic between X amount of time of them making the incision, the rate of them having an infection at that site is decreased tremendously. So that is why you will not see them, you will have them see them connected and you will have them see it open wide open. Okay, so there's a reason, and that's a specialty area, and you may see it in other specialty areas, but I know being in the OR, I do not see them count drops. And I'm okay, because I know research backs that up. Okay? All right, the other thing I want to tell you real quick, well, I guess I could wait on that. All right, so priming the tubing, we're okay. We know what we need to keep sterile. Practice with that. IV piggybacks, back priming, and of course we're going to have time to practice from 11 to 12. Okay, so we can get in here and practice. We'll also do IV push in just a minute, but I'd like to do from 9 to 10, do the calculations. When I have a gravity IV fluid, how do I measure that? Drops per minute. If I have a pump, milliliters per hour, cc per hour. That is going to make so much more sense when you sit down and do the calculations. Okay? All right, do y'all want to take a 10-minute break?